Welcome back to Ending the Arkansas Opidemic, the vodcast that takes a deep dive into the opioid epidemic in Arkansas. My name is Dr. Cheryl May. I'm director of the Criminal Justice Institute, and I will be your host for this episode. Joining me is the Arkansas State Board of Pharmacy's Executive Director, Dr. John Kirtley. In recent years, opioid addiction has plagued communities across the state, and the number of overdoses and fentanyl-related deaths have steadily increased. Nationally, over 110,000 people every year die in this country. That's 305 people every day are dying from a drug overdose. While we've made an enormous amount of progress, there's still a lot of progress that is yet to be made. In Arkansas, we've had 437 deaths in the past year, which is actually close to 40 deaths less. So we are making some significant progress. Today, Dr. Kirtley and I are going to talk about a variety of issues. One of the things that we do know is that in order to combat this epidemic, that it's going to take everybody. And Dr. Kirtley and I have worked together for a long time with a number of other partners and have made significant inroads into trying to curb the number of folks in our communities that are suffering from opioid addiction. Pharmacists have played a very, very valuable role in this fight. And one of the things that has come on the scene and has been on the scene for quite a while is a drug referred to as naloxone. And as we know, naloxone is a temporary antidote that will temporarily, and yes, we're emphasizing temporarily, reverse the effects of an opioid overdose. So, Dr. Kirtley, first and foremost, thank you very much for being here. Would you tell us a little bit about your background?
Absolutely, and thank you for having me, Doc May. For my background, I'm professionally trained as a pharmacist. I graduated from the UAMS College of Pharmacy back in 2002 with my Doctor of Pharmacy degree. Even during pharmacy school, I took some focus on helping people that had different hang-ups. We had a section called Student Outreach Services, so that if you had a friend or a classmate that was struggling with something, whether that be the work that we actually had to do in pharmacy school as far as the scholastic side of it, or something with their interpersonal health, something that was stressing them out, something that they might be struggling with, trying to be a resource for classmates and friends, for someone to talk to. After pharmacy school, I went and worked in a community pharmacy here in Little Rock, where I actually was able to connect with patients on a daily basis, helping them with their prescription drug needs and helping them make the best use of their medications. After that, I did teach at the College of Pharmacy for a year before roaming over to the Arkansas State Board of Pharmacy, where I've been in a regulatory role with the state of Arkansas for right at 19 years now.
Wow, it's amazing how quickly time passes.
It is. I had a lot more color in my hair back when I started.
Yeah, we're not going to talk color of hair today, please, sir. But we're very, very happy to have you today. We're going to focus on naloxone. Would you tell us a little bit about naloxone as a drug, what it does, and why it's important in opioid overdoses?
The easiest way for me to generally talk about naloxone is in lay terms. And basically, it's an opioid blocker. It's something that actually can help to block the effects of opioids. And I usually talk about it in terms of, golf balls and eggs and golf tees, because most people kind of understand that. So if you're talking about different receptors in the body that different drugs attach to, you could think of it as a golf tee. And an opioid would be very much like a golf ball. It sits very well on a tee, but it can also be knocked off. Well, while that is on that tee, you're getting the effects of the opioid, which could be, for some people, euphoria, could be pain control and pain management, but could also cause a decrease in basically their brain's activity, or a depressive effect where it can actually decrease their cognition, their breathing, and everything else. Now, where this is interesting is naloxone I would describe more like an egg. It is not as durable as the golf ball, therefore it doesn't last as long as sometimes the opioid could. But since it wants to be on that tee more, it can basically displace or knock that golf ball off, knock the opioid off that receptor, which stops those opioid effects. It can stop, any analgesia, but it can also stop that neurodepressive effect that is interfering with people's ability to breathe. The really important concept in this, which I use a golf ball and an egg, is that opioid is on there and will last longer than the egg. It's actually a more durable drug or could stick around longer. So when we see the use of naloxone, you have to keep in mind it is a temporary fix, and you need to get towards more clinical care because it could wear off and you could go back into an overdose situation as that drug wears off because the opioid is still in your body.
Yeah, and could you just talk just a little bit about how to recognize somebody that is overdosing?
Absolutely. One of the things that you really have to watch is a lot of people want to be cautious and they're afraid that they're going to harm someone if they misdiagnose or if they misunderstand this. But what we generally see and what we generally hear from different partners is, people almost look like they're dead. They're barely breathing or they have significantly suppressed breathing, and they're very difficult to rouse, if not impossible to rouse. You'll talk about in some trainings, and just like with the apps that we use, like Narcansaw app, I know we're going to talk about, you'll do things like take your knuckles and do a sternal rub on someone or gently shake them or try to get their attention. And if you can't rouse them, oftentimes they will also have their lips maybe turning a shade of blue or their ears maybe turning a shade of blue, which is a sign that they're getting really poor blood perfusion.
Mm-hmm. And you talk about it and you emphasize the fact that it is temporary. How temporary is it? Can you put a timeline on that?
It's actually interesting because it's very difficult to put a timeline on exactly how long naloxone may work because generally we don't know what all opioids are in someone's system. So if we have someone on prescribed drugs, we generally have a general idea of how much medication they've actually got in their system, but it's very difficult to tell just from looking at somebody how much opioid is in their body attacking or trying to attach to those different receptors. So when we live in a world where fentanyl is very, very prevalent and very potent, we really have no idea what is in these street drugs. When you look at statistics that say that many of the fake pills, and I say fake pills because they're not the actual pharmaceuticals, many of them have a fatal dose of fentanyl. So when we say temporary, it's you may have to give multiple doses of naloxone to initially reverse that person's actual opioid overdose. It's not necessarily that one shot actually will cure it or will stop it. It may take 2 doses, may take 4 doses. We don't know. You have to dose to effect on this, and you have to be careful because it could wear off in 10 minutes. It could wear off in 30 minutes. It could wear off in 2 or 3 hours. So that is really why we point out people need advanced clinical intervention or access to further clinical care whenever you're using these medications.
Yeah, and basically what happens is that person stops breathing again, and they literally go into an overdose.
And that's a great point because talking to several of my friends, especially my law enforcement friends that have used, Narcan nasal spray or naloxone on somebody, they will tell you that, the person is basically on the ground or on the couch or they're somewhere, and it's like it's a body. They do not appear to be alive, and they'll dose a dose. Sometimes they'll dose a couple of doses, and all of a sudden it's just a and the person just comes back awake. And they said the first time that they ever saw it, it just almost scared them. Like they shake and jump back because it is so sudden of a thing at times when they come back. It's unexpected.
Yeah, and you mentioned fentanyl. And, we do have programs that are basically focused for first responders and wanting every first responder to be able to carry naloxone because they're the first ones that are on the scene. And it's primarily due to fentanyl. What are the side effects of naloxone? Are there any?
It's funny because in many ways, we would caution people that, the worst thing you generally could do if you misdiagnose someone with an opioid overdose and you give them nasal spray naloxone especially, you've made their nose wet. For someone who is opioid dependent or who is in an overdose situation with an opioid, I mean, naloxone will kick all those opioids off those opioid receptors. So if you've been using it for pain control, then you could come back when you come to, you could be in pain again. People that are using it for euphoria, they lose that high. Sometimes our first responders will tell us that people that they've Narcaned, that they've given naloxone to, that they're upset because they lost that high, and it pushes them towards kind of a status of withdrawal. But we can treat withdrawal.
Yeah.
We can actually help with withdrawal. There are other medications and other interventions that can be done for that versus I understand you're upset that you're now in withdrawal, but you were dead or you were dying.
And it's my understanding that when first responders do administer naloxone, that it's up to the patient whether or not they go to the hospital. But I'm sure you want to emphasize how important going to a medical facility
Absolutely. It's something that I think in a lot of instances, patients that have been in an overdose situation, when they come to and they're surrounded by first responder, whether that be, the firemen in the area, the EMTs, the police officers, that freaks them out, quite frankly. And they they basically just want out of the situation. I'm fine, let me go. And so we really do emphasize the fact of you may be fine right now, but if you walk away from this situation and we don't have other people ready to dose you again or to help stabilize you if needed, or to breathe for you, well, you could be right back in the situation that you're not aware of, but everyone else in the room saw. And it's just a matter of time. You're a ticking time bomb that you really can't predict whether or not that's going to happen.
Yeah. And let's just spend one more minute talking about fentanyl and why fentanyl is so dangerous. We know it's a synthetic or laboratory-made opioid, but why is fentanyl so dangerous?
Well, fentanyl is an interesting drug all by itself. It's an interesting medication all by itself because it has incredible use in specific areas where you're generally monitored, especially in high acute doses. They can use it to knock you out for surgery. They can use it for anesthesia in that example, and also for severe pain control. But what we're dealing with, especially on the illicit side of fentanyl, it is incredibly potent, where we are talking about, a number of pills for most different types of opioids potentially putting you at risk for overdose. With fentanyl, it's granules. I mean, when we talk about how potent it is, if you think about a packet of sugar, or a packet of Sweet and Low is a great example. A packet of Sweet and Low is 1 gram. If that was pure fentanyl, that would easily be enough to get 1,000 people high, but it would be considered to be 500 fatal doses of that medication. That is how potent it is.
Yep.
And we don't know what's in the pills.
Yeah.
You would trust your local drug dealer or whomever they've obtained it from that they've made sure it doesn't have a fatal dose. But as people that have an addictive disease are, chasing that dragon, chasing that high, they're looking for what the next strength up is or what the next most potent thing is. And you just really don't know with what you're getting.
The really unfortunate thing about fentanyl is that they're putting it in a wide variety of different types of drugs, even stimulants like methamphetamine and cocaine. But the one that gets me the most is them using liquid fentanyl on marijuana.
And that is one that really shocks me from time to time because, for a lot of people, they think that, injectable drugs are off limits or pills are off limits. But a lot of people think, well, marijuana, it's grass, it's natural, or they don't think that marijuana might have something else in it that is an absolute killer. So they have a false sense of safety, they think, if they're just using marijuana. And that is absolutely not true today.
Yeah, that's a great illustration of that point. So, we've talked about naloxone as a general category of a drug. And there are a variety of different ways that we can actually administer naloxone. Would you spend a little bit of time talking about that?
Absolutely. When we generally are talking about naloxone at this point, and generally when we're talking about the use of it in the overdose type of situation, we're generally talking about nasal spray naloxone. And even with nasal spray naloxone, there's a couple of different types. There's the self-enclosed type. I have examples here so I can actually show the camera. This is the way that we actually would see it for Narcan. It's just a little self-enclosed thing that you put it up in someone's nostril and you push a plunger. This is the easiest, most accessible way to actually use naloxone. There's no needles in it. And I say that because a lot of people are needle weenies. They do not like needles. They don't want to mess with needles. They don't want to risk a stick of a needle or having one exposed to them. But there's also nasal spray, the old style we started with. It's been a few years, but it would literally be a syringe that you'd put a little device on the end that we'd call a mucosal atomization device, and you would push the plunger. But instead of being this tiny amount of liquid going in someone's nostril that was concentrated, it would be a couple of milliliters, which 2 milliliters doesn't sound like very much liquid until you spray it up someone's nose and realize how much liquid it is. But that was not as concentrated. It was not as easily handled. It was in glass containers that at times you could have those broken. So you think you have naloxone and you get to it and you realize, well, it's already been broken, so it's not going to work. The third way that we generally see is there are some auto injectors where it actually has a needle. The example that I have actually will talk to you and talk you through it, but those are very, very expensive. So traditionally, the lowest price point has been the old style syringe with a mucosal atomization device, and we could potentially get it for $25 a dose or something like that. Originally, Narcan, which is what this would be like, Narcan was about $75, $70 a dose at retail as a prescription-only product. Now, more recently, as we're both aware, we've seen that go over the counter. And the over-the-counter 2-dose kits that I'm watching right now, they run about $45 for 2 doses.
Could you talk a little bit more about the significance of it going over the counter?
Absolutely. It's very interesting in some states, including Arkansas. Our legislative leaders, our governor, our attorney general, and other leaders like yourself have long advocated that we need better access to naloxone. And we've had really good laws for, Good Samaritan protections for the use of naloxone when we think we're trying to help someone with the opioid overdose situation. And along with that, Arkansas had basically gone through a series of laws making it more accessible to where at this point it basically is almost an over-the-counter drug in Arkansas by statute or by statutory default.
Could you talk a little bit about, one of the first steps that was done is that there was a standing order for naloxone?
Absolutely. A few years back, we actually had legislative initiatives where we had naloxone as a standing order to where for participating pharmacies, any patient could go in, any member of the public and could actually request naloxone. And the pharmacist could go through and talk to them about if you are either at risk for an opioid overdose or you may come in contact with someone who's at risk for an opioid overdose. Then either the pharmacist could directly basically prescribe that and be the prescriber of record and provide that to you, or the standing order actually had, it was a member of the team at the Arkansas Department of Health, one of their medical directors who's a physician, that you could use their name if you needed it for billing purposes to get it through insurance.
Yeah, and then recently there was the law that was passed that focused on co-prescribing.
Absolutely. The other thing is when we really look at prescribing habits in the state of Arkansas, and this isn't a disparaging comment about our state, but when we started getting data through the Arkansas Prescription Drug Monitoring Program and then the national data that compiled that, we figured out that we are the number 2 state in the country for the prescribing of opioids on a per capita basis. And Arkansas has made great strides in reducing our overall opioid dependence, but the entire country has made great strides in that. So when you look at a state which we have rural areas throughout the state, we have a lot of hard workers that are mainly doing physical labor. They generally don't necessarily have the financial means to take 6 weeks or 3 months off of work to have some sort of surgical repair to whatever they may be taking pain medications for. So we have a high opioid demand in our state, and we have for many years.
Right. But the whole idea of getting a prescription when you're prescribed opioids is not necessarily to combat the illicit fentanyl. It's to reduce the risk of something like accidental overdose, correct?
Absolutely. And I apologize I didn't better state that. In many ways, when you look at the criteria of patients that are being prescribed opioids, there are certain levels, like over, say, 50 morphine milliequivalents a day, which is a decent dose of it, but not an unreasonable dose of an opioid. Well, the statistics will show you that you have about a double incidence of a potential overdose at that level. And then as you get higher, it actually can become an exponentially higher risk of potential overdose. So one of the great comments that we got during the Stop Overdose Summit last week was a physician in our clinical section, as we were talking about, well, if you're co-prescribing this and there's a lot of hesitancy from some patients going, why would I need this drug? I'm not going to overdose.
Right.
And he pointed out that especially for him working with elderly patients,
Right.
and he said, I'm not picking on elderly, but I'm saying that when opioids can cause mental confusion for someone who hasn't been used to taking something, it's real easy when you throw some of these medications on board that it's a situation where I'm in pain. I can't remember if it's time for me to take another pain pill or not. And you go ahead and take it and you don't realize that puts you over the edge for potential overdose. The other aspect of that is, what if someone else accidentally takes one of your medications, not realizing what it is?
Like a child, for example, gets access to it.
We have seen that absolute example throughout the United States in the past that, a lot of these kids think it's in a pill bottle, it's basically safe, and they miss the point that it actually has great risk.
Or me, my focus on young kids, a child being able to actually reach the medicine and accidentally get overdosed. So naloxone has become quite an important way for us to get a relatively smaller subset of individuals relief from an overdose. The FDA recently approved one administration for over-the-counter. Would you talk about that a little bit?
Absolutely. It's been fascinating watching throughout professional circles for several years that a lot of us have believed if you truly want open access to this life-saving drug, realizing how many lives are being claimed a year by opioid overdoses, there were petitions sent to FDA, and finally one of the manufacturers even applied to say we would like to have this with over-the-counter status. And really what we have is the exact same Narcan product we have with different labeling. When the FDA approves drugs to be for self-care use, it has to have self-explanatory instructions and cautions that are more appropriate for a patient to be able to go and actually look at that product over the counter and purchase it directly. So we did have that approved. It was funny. I know you and I have had some discussions. We kept going, when's it going to be on the shelf? When's it going to be on the shelf? Well, it's on the shelf now. And the two huge effects that I see for this is, one, I think it helps to destigmatize the fact of being able to purchase Narcan or naloxone directly as a member of the public without having to go and seek some sort of intervention or some sort of interaction with your pharmacist, with your physician, with your nurse practitioner, or whomever else. But it also greatly reduced the financial burden to people that wanted to do it. So no longer do I think, well, I have to go to a visit for my prescriber and pay them for the visit and then go to the pharmacy and pay a copay or out of pocket. So not only was the price greatly reduced, the overhead of how you get to that price point has also been reduced with it being in over-the-counter status.
Yeah, and we talk about how the opioid epidemic is not specifically focused on one group or another, that there aren't any socioeconomic barriers, and talk about how naloxone is beneficial in that area.
It's kind of interesting when we talk about past drug addictive issues and lives that are lost and everything else. Oftentimes they are attached to some specific subset of the population of, it's those people or it's the other people over there. And I think what you and I would agree to is this is an epidemic that affects all of us, not all of them, all of us. Because most of the people that I have dealt with that have suffered from some sort of addictive disease, the vast majority, and I can even talk about in the pharmacist population I've dealt with, the numbers are extremely high that many times the exposure to the drug started with a legitimate medical reason with a prescription drug. And I think there's a lot of misunderstanding, and I can see it in the faces of patients when I would try to counsel them, that a lot of people think, well, if I have a prescription for this, I'm never going to be impaired from it. I'm not going to ever become addicted to it. It's never going to be a risk for me or my family. And I treat, even as a pharmacist, these medications with a great deal of respect and even sometimes a bit of fearful respect,
Right.
that I have to understand that could affect me differently than I expect.
Yeah. And we talk all the time about how opioid overdoses and substance use disorders or opioid use disorders, impacts everybody in the community. And, when we talk about that stigma, one of the things that I've always said is that, who are these individuals? They're our sons, our daughters, our
Absolutely.
husbands, our wives, our moms, our dads, our neighbors, our coworkers. So I appreciate you emphasizing the fact that we've got to really, really work on this stigma, because it can impact us in an instant and not be able to predict whether it's going to happen. We've spent a lot of time talking about naloxone. Do you think naloxone is like a silver bullet that's going to be able to that's going to end our problem, that if we get everybody equipped to carry naloxone, that our opioid crisis is going to be over?
Absolutely not. I think everyone is looking for that great panacea on these problems, and this is a tool in our tool chest, but it's not the only one. And as I know you and I have discussed many times, generally when we are dealing with someone that is suffering from any type of addictive disorder, whether that be opioid use disorder or anything else, we need other tools. We have got to be able to connect to them emotionally. We have to encourage people that at times what you need is you need a counselor, you need a psychiatrist, you need a trusted friend that you can talk to. And I do love the point that it's everywhere. And I think you and I have both probably offended some people over time when we have said this is in every family in Arkansas, this is in every family in America. And if it's something you haven't seen, then either you may not know exactly what you're looking for, or you haven't looked very hard.
Right.
Some of the exercises that I love in this, that I think really help to erase stigma and help to humanize the fact that this is an actual disease. In pharmacy school, we had an addictive disease course, and one of our assignments that a lot of people got mad about was we had to actually go and attend a couple of open AA or NA type meetings with, drug addicts or alcoholics. And it's been fascinating for me seeing the connection myself with people who looked like me, looked like my friends, looked like my family when I went to those meetings early on as, a 21-year-old kid basically, and then seeing students for years after that. And how I had one student one time that talked about how angry she was that she was being forced to go to a meeting with quote, those people. And she went to the meeting, and it was a meeting where they were going around the room sharing. And the immediate panic hits that they're going to get to me. And it's very easy to say, I pass in that meeting. I don't have anything to share. It's an open meeting. But then she was upset because she said there was another girl in there. She said that absolutely reminded her of one of her good college friends. And she had on cute shoes, and she was dressed nicely, and she had a cute purse. And she's like, this person looks like me, or like one of my good friends. And she was later upset because as they went around the room sharing, it stopped before it got to that girl.
Yeah.
And she was upset. She goes, I wanted to know her story. And so it's fascinating how quickly the attitude can change when you start to connect with some of the people that have really walked through this and have suffered through it, that they're not different from me and you. They have some of the same struggles that we do. It's just their end point or their midpoint or where they are right now might be slightly different.
And, because it's such a complicated issue, it's great to be able to have naloxone as a tool. But as we've always talked about, you need the treatment and also have to have recovery.
Absolutely.
Is there anything else you would like to talk to us about as far as naloxone goes?
I think with naloxone and addictive disease overall, I think that you and I would both, keep sharing the message that just because you see someone that is dealing with this, that's not something that you're going to throw away. Everyone, as long as we have breath in our lungs, there's hope for that person. I think a lot of people really struggle with how to deal with this. And I would encourage my friends, sometimes you need to reach out and you need to find a counselor. You need to find a psychiatrist. You need to find someone with expertise you don't have, and you need to be willing to ask for help. The other aspect of that is whenever I have a friend that comes and shares with me that they have sought some sort of counsel for that, I encourage them, because the worst thing I could do is discourage them if they identify and have taken that courageous step to look for some type of help.
Thank you so much again, Dr. Kirtley. We've been in this fight for a long time, and I'm afraid because of fentanyl, we're going to have to continue this fight. But the important thing is that we're fighting, and you've made a tremendous contribution, and we greatly appreciate everything that you've done.
Absolutely. Thank you.
And will do in the future. Thanks again for tuning into today's vodcast. You can find more information about naloxone and other free resources on the Narcansaw app, which is available for download in the Apple and Google Play stores, or at www.narcansaw.com.